So welcome to the 2021 virtual series, the Forum on Aging in Rural Oregon. Would like to start off by introducing the forum. We are hosting a virtual series of forum sessions this year every third Thursday from 2 to 3 p.m. This year, or this session, we're going to go a little bit longer because we've got a lot of content to cover, and my understanding is that you folks in the community may have some questions, so we'll have time for questions and a dialogue towards the end. Rather than the in-person event this year, we're doing everything virtually. We do plan to be back in person in 2022, though, so if you're not a part of our mailing list, please do join so you can get updates and whatnot about future forum activities. I want to start by thanking our partners this year. We've got Gobi, we've Central Oregon Health Council, as well as the Older Adult Behavioral Health Initiative, supporting the educational outreach and efforts that we're doing and allowing you all to access this information for free, as well as free continuing education units. Next slide, please. So we've got Terry Schroeder and Tim Malone joining us today, and neither one of them have conflicts to disclose. Next slide, please. And before we go ahead and jump into our session today, I will get you all somewhat oriented to this virtual platform that seems to change and evolve on a regular basis. So as attendees, your audio and your video are muted. We're going to please use the Q&A box. That's going to be selecting the 3 ellipses to the right of your chat function. If you have questions, please use the Q&A so it doesn't get lost in the chat feed. If you have follow-up, you're welcome to ask that as well. If you want me to unmute you, just indicate so, and you can ask your question using the audio. Chat function for everything else. If you find yourself dialoguing in the chat, that's as well, that's okay. If you find that I didn't get to a question that you asked in the chat, just put it in the Q&A, please. These slides, as well as the recording, are going to be posted shortly after the session on the Oregon Office of Rural Health Forum webpage. I will put a link to the evaluation, the survey of this presentation in the chat at the end. And so if you do want continuing education units for this session, please complete the survey. That is how you will get those education units. Next slide, please. All righty. Now let's get down to it. It's my pleasure to introduce our speakers today, Terry Schroeder from the Civil Commitment portion of the Oregon Health Authority, and Tim Malone, who is a private practice Gero-Psychiatric social worker. They're going to be talking to us today about working through the challenges, how to address complex Gero-Psych interventions and management. So I will stop talking and let these fellows get down to business, and really appreciate the 2 of you being here today and all of our attendees for joining us. So without further ado, I'll hand it over. Next slide, please.
Hi, everybody. Tim Malone here. I'm going to talk first here. Yes, my slides are very dense, but I created them also to be handouts for you. And so I hope you can enjoy that. But anyway, we'll just dive right in. What constitutes a Gero-Psych complex case? It's the confluence of 2 or more of these. Mental illness, usually things like schizophrenia, bipolar, some other major mental illness, but can also be, pretty serious major depression and or anxiety. Things like hoarding can really create havoc. Personality disorders, usually borderline or antisocial, could be any of the others. It's really, you need to be really clear about what you're going with there, though. Dementia, which dementia means your brain doesn't work right. Okay, that's all it means. So the etiologies are important. Such as Alzheimer's or stroke, alcohol, drug-related, head injuries, that sort of thing. And so don't let anybody tell you, well, he's got a head injury, he doesn't have dementia. No, head injuries are one of the etiologies of dementia. People, when they say that, they just don't want to pay for it, right? So brain damage from substance abuse is a common etiology, more common these days. Substance abuse, ongoing, current, alcoholism amongst seniors. There's a lot of prescription drug abuse. Sometimes it's not really abuse, it's mistaken use. Okay, usually pain or sleep meds. Physical debility, particularly in homeless folks, often have that. A lot of seniors too have, unaddressed physical problems. Diabetes is a big one because it can alter both physical health as well as cognitive health. Poverty and or homelessness. And in my mind, that simply means that you don't have enough dollars for the necessity, or you have an inability to manage your dollars. And there's plenty of essential workers right here in Bend who are homeless because they simply don't make enough money to garner services of any kind. Social isolation simply means you don't have social support system. Usually it does mean you are physically isolated somewhere, but people living on the streets surrounded by a lot of other folks, they're quite socially isolated as well. Violence from any source, any etiology of violence could be a piece of it. Recent criminal history, people don't want to give services to ex-cons, people everywhere, or current involvement with the legal system certainly complicates matters. So as I'm going to say many times, a lack of geriatric specialties, both medical and or mental health, that enhances any problem you're coping with. Next slide, please. So impediments to any positive outcomes. Now, these are not listed in any order of importance. Okay, to me, they're, if not equal, pretty close. So, you're in a community where there's just a lack of experience or skills in differential diagnosis. And what does differential diagnosis means? We're trying to figure out what's the etiology, what's going on here, what do we need to do about it? Okay, that's a lack of experience amongst mental and physical health providers, and what kind of treatment to provide. You can know, well, I know they have Alzheimer's, but now what do I do? Okay, a paucity of service agencies that have knowledge or skills in geriatric issues or geriatric mental health, but also the willingness to provide. Little known Oregon statute is that every mental health agency in every county in Oregon must have a trained master's level geriatric specialist. I just talked to one county mental health yesterday. They didn't even know the English words behind what I just said. I mean, that's how bad it is. There's over 30 counties in the state that do not have a trained geriatric specialist. So the financials involved, of any agency involved, we have finite financials. The state itself, the big state, has finite amount of resources, for getting people on Medicaid or putting them into a care facility, or they have very narrow or inflexible criteria, even if that isn't what actually exists on paper. They're kind of operating it that way. Inadequate insurance, payment sources. For seniors, of course, Medicare, Medicaid, primary sources. Yes, you can have well-to-do people in complex cases, but nobody's operating their Medicare system or their private Part B or any of that. Social stigmas definitely still exist. Excuse me, I don't know what the hell's going on there. So mental health, old age, homelessness, addicts, disability, being poverty-stricken, your ethnicity, those all still apply. And we need to, kind of look at ourselves and our agencies to see how much those apply in care decisions that we make. Agency silos, we all know what that is. It causes unnecessary expense, replication, duplication, and possibly no services because, well, the other guy does that, not us. Okay. Agencies that don't talk to each other. Anybody, raise your hand if you know anything about that. Lack of functional interagency relationships and partnerships. That's huge. Okay. I mean, back in the day, people would ask me like, Tim, how do you get along with those crazy people over there at State Aging Services? And I said, well, I know what their first name is and I know what beer they like. And when we call each other, we actually do something. You can do that too. It's really not difficult. Agencies that don't talk to each other. There's some of that right here in my hometown. I hate to say, lack of functional interagency relationships and or partnerships. We'll talk a bit more about that in a bit later. Public-private agencies are seen as different, incompetent, unwilling. It's their problem. a poor understanding really of what each other's are supposed to do, can do, or will do. Okay. Poor social service agency understanding of or connectivity to the local law enforcement and court system. They really don't know who the DA is or the local judge, and the names of the local police officers. Poor community and social service agency understanding of what is legal capacity, what are mental health holds, what's admit criteria for state hospital, for private geriatric hospitals, what are the police capabilities? Might be different from one community to the next, different between, your city and your, county police. What is the abilities of local hospitals and or what are their actual responsibilities? And so I'm going to let my colleague Terry tell you all you need to know about that. Next slide.
All right, actually, Eric, can we step back one slide first? Great, thank you. Hi, everybody, and thank you for that introduction, Tim. So again, my name is Terry Schroeder, and thank you all for coming. I know there's a wealth of information, skills, and experience out there that spans decades. My experience goes back about 40 years as well as, I think Tim is around 50 or 60 years, but I'm not sure. I'm getting a little bit of feedback. Tim, can you mute you? Maybe
yes, I can. Yes, I can.
Okay. There, that's a little better. One of the things I wanted to do was just introduce myself. I am the Civil Commitment Coordinator along with Sam Dixon at the Oregon Health Authority. I provide the civil commitment training that's required for people to become investigators and examiners for the state. And I also do the certifications for all of the psychiatric hospitals across the state. And Sam does the secure residential treatment facilities, residential treatment homes, foster homes. And both of us, we are primarily involved with any situation that has a statutory or rule related issue around custody or civil commitment. And so my goal in this training is to just describe some of the principles behind what constitutes criteria for civil commitment, how does the civil commitment process work, and what are the systemic, medical model, social cultural issues that contribute to the challenge of working with really complex cases, as Tim was describing, and the spectrum is huge, right? I mean, we're talking about folks who have, because of their aging, because of our aging, vulnerabilities to medical problems. We also carry histories with us, are both of trauma and or poverty or other kinds of learning experiences that impact the way in which they handle stress or crisis. We have any number of different kinds of family structures that are sometimes helpful, sometimes very not helpful to getting change to happen in a positive way. And we're also dealing with folks who oftentimes find it difficult to ask for help when they're functioning at their best. I'm one of those people myself, actually. But when you add mental illness and other kinds of impairments to the mix, which strip away the ability to have the insight and the judgment needed to understand and recognize the need for help, it becomes even more complex. And so you have medical impediments to this, the siloing that Tim talked about, where different agencies aren't working in a collaborative fashion. Here in the state of Oregon, we also have issues around capacity. And what I mean by that, just not enough beds in the continuum of care needs that people have, because these things are all fluid and dynamic too. I mean, they change over time. Sometimes they change rapidly, and our system has to be able to adjust to all of that in a flexible way. And in order to be flexible, we have to have good communication and collaboration with each other, because otherwise it ultimately ends up being a burden of one or two agencies trying to manage and get everybody else on board. And I'm sure that's probably what most people experience, is that there's one or two groups of people who identified a problem and now trying to get the rest of the system to respond effectively to that problem. And that can be extremely difficult to do and challenging and frustrating and can cause burnout among many other things. I think just in part, I want to recognize that we're talking about these complex cases because they're incredibly complex. And all of us, we don't live in silos. We're all very unique individuals, and our situations are unique, and every situation has its own nuance, challenges, and opportunities. And it's really important for us to seek out what those challenges and opportunities are. In talking about the impediments to positive outcomes, one of the things that from a mental health standpoint and a crisis intervention, civil commitment, custody point of view, it's important for clinicians and people who are engaged with these folks to be able to understand what it is the crisis worker and the law enforcement person are looking for in terms of information. And one of the things we'll talk about further too is that one of the skill sets that people need to be effective in these situations is to have the ability to communicate effectively with different groups based on the need of that group to hear what helps them take action. And another way of putting that was kind of clunky. Another way of putting that is saying each group has certain sets of criteria that they need to hear and know about in order for them to be justified in doing something for that person. And so when we're communicating about an individual, we need to be able to know what those points of information are, what that data is that that person needs to know. So a law enforcement officer considering taking somebody into custody is going to need a certain set of things. The crisis worker, same thing. The hospital ER physician is also going to need to know certain kinds of information that allow them to justify continuing to hold them or evaluate them or make referrals to other kinds of treatment. And that is also going to be true for family members. They're going to want to know certain kinds of things that are specific to their needs. A psychiatrist who's considering admitting somebody to a hospital is going to need to know certain kinds of things in order to justify the medical necessity, as it's called, for the admission, and so on and so forth, with guardianships, with courts, etc. So it's important to know what your listener needs to know in order for them to be justified in taking certain action. And that doesn't mean diminishing or not stating things that also are part of the equation. For example, the conversation between mental health and a medical disorder or a brain disorder needs to happen. But one does need to be able to know what that mental health disorder is, how the onset has happened, if it didn't, what was the onset of that mental disorder, what are the functional impairments that are directly a result of that mental disorder, and what are the lack of mitigating or support services that keep that person safe. And so what's the onset, what's the functional impairment, and what options have been considered but ruled out as effective to keeping that person safe. These are the kinds of things that, for example, a crisis worker is going to want to know. I think, yeah, so could we go to the next slide? This is everything you would ever want to know about civil commitment. and I'm kidding here. This is a slide that basically is a flow chart for what the process is for custody and detention of what is legally termed a PAMI or an AMIP. Both terms are used interchangeably, or acronyms are used interchangeably in the statutes. And a PAMI is a person allegedly mentally ill. The word allegedly is what gives you the indication that the person has not yet been civilly committed. And so within the statute vernacular, a mentally ill person is somebody who has been civilly committed. A person who has not been civilly committed is somebody allegedly to be mentally ill and is in the process of being evaluated for possible commitment. So that's where that word comes from. It's an unfortunate phrasing, I believe. It isn't complimentary, so to speak, and or sensitive to really what's happening here, but that is the legal terminology for this. And when I do my civil commitment trainings, this slide is what I spend an entire 8 hours talking about. And I would say it's not even a deep dive into that training. It's about a medium level of complexity and information. Typically, I'm talking to people who have not done civil commitment work before, who may be new admissions into the civil commitment world and the crisis team world. And so I have to make sure that the information isn't so complex that it overwhelms them. And at the same time, there are a number of people in these trainings who have done this work for many years. And so I try to hit a middle ground in terms of complexity of the training, but we go from the initial contact out in the community. So a crisis has erupted, somebody has notified an official, such as a law enforcement agency or a crisis team, and the information, again, is relayed such that it triggers them to go out, and that's an important piece. And so when the concerns are being given to the crisis team or the law enforcement officer, it's important that information really hits those chords that allow the officer to go out. And it's basically, we feel this person's at risk, and here's why. And we feel like something needs to happen now or somebody will get hurt one way or another. And we think that there's a mental disorder going on, so please bring a crisis worker with you. Or the crisis worker will offer to have police accompany them in order to make sure that the scene is safe. It's not unusual for these situations to have the potential for violence or have recently been violent. And so it's important that the law enforcement and the crisis worker work together. And then once they're taken into custody by one of these three folks, the police officer, the community mental health officer, which is really the crisis worker or director's designee. In statute, directors of mental health centers have the ability to assign designee status to a certain group of people in the mental health center to have the authority to take people into custody for the purposes of being evaluated. So it's a very short-term custodial authority, but they do have the ability to do that, and we'll get into that a little more in just the next slide. And once they're taken into custody, I'm sorry, Eric, I didn't mean to go. Thank you. Once they go into custody, then there's an evaluation to determine whether or not the person is a danger to self or others or unable to care for basic needs. And there's been some recent statutory language change around that issue that I want to talk about too. And then if the evaluation is such, based on probable cause level of evidence, they then can hold that person for up to 5 judicial days, and there's some exceptions to that too, for the purpose of evaluating for civil commitment. And then from there, the person goes to court and there's a hearing. And there's a lot of complex steps and sub-steps within all of this, but this flow chart basically describes what those steps are. It doesn't, of course, tell you what happens inside of them though. Next slide. And keep going. And again. So what this, nope, back, sorry. Yeah, I just want to make sure that the language came up. So this is the statute, which is a 426 statute, 228, and the OAR 309, 033, 0230. The 033 rules are the rules that the Oregon Health Authority makes up to help offer guidance as to how to implement the statutes. The statutes are legislative law, and so these are the things that we can't go beyond. It sets the guidelines for civil commitment, and the history in Oregon is that these civil commitment statutes were revised in a major fashion back in the early 70s, 72, 73, and they have not been revised in a major way since that time. So therein also you see that the understanding of civil commitment, understanding of mental illness, the understanding of the impact and interaction between substance abuse and brain disorders, all of the statutes are reflecting the understanding of the 1970s regarding these issues. And we've come quite a ways from there in terms of the interactiveness of these dynamics with one another in our understanding, but our statutes and our rules really have not evolved in the same pace at all. And the statutes are all individualized from one state to another. So Oregon statutes are different than Washington statutes or California's or Idaho's or Montana's. And I've done civil commitment work in all three of those states. And It is done differently because the statutes are written differently in some respects. Montana and Oregon are very similar in their statute. Washington and California are more closely aligned than they are with Oregon. So I could go on forever about all of that sort of stuff, but that's not why we're here. But it is important to recognize that Oregon is individual in its statutory arrangement, as is any other state. And there's no reciprocity between one state and another. So if a person's civilly committed in Oregon and leaves the state to go to Washington, they will no longer be a civilly committed person, at least according to Washington. Next slide. So a police officer initiated custody basically is a fairly simple process in that when a police officer encounters somebody and they've determined per their experience and training, and again, that's an important piece, per their experience and training, they've determined that the person has a mental disorder, and that mental disorder is resulting in a potential risk to someone else or themselves. And the more training that an officer has, the more sensitive and more nuanced that judgment's going to be, of course. Officers are extremely skilled and talented in terms of making behavioral descriptions and seeing details in behavior and environment and context. Extremely useful to a crisis worker for that purpose. But they're not necessarily trained as mental health people, right? I mean, they have their own cultural experience of working with people on the streets. They have their own training within their own agency. And in many counties that have instituted the CIT training, crisis intervention training for law enforcement, which I was the coordinator of for Deschutes County when we first put that together, makes a huge difference in terms of a couple of things. One of them is the ability to work collaboratively with mental health because there's an increased awareness of the shared roles and responsibility and the interfacing between the two agencies, and also a greater sensitivity and understanding to how mental illnesses may express themselves out in the street. And so those two things are really helpful for an officer to get that kind of specialized training so that when they're working with somebody in crisis, they can begin to discern the difference between criminal behavior and attempts to avoid consequences and any number of other things versus somebody with a mental disorder who is acting out of that mental disorder in a way that they believe is appropriate, but because of the mental disorder, there's a huge distortion in their understanding of what's happening. So the officer has the authority to take somebody into custody if they have probable cause, and probable cause is a fairly low level, it's the lowest bar for authority to take somebody into custody. And it's basically a reasonableness standard, which so another way of putting that is, would it be reasonable for any other officer under those circumstances to make the same decision? Is it reasonable to suspect or believe a mental disorder is driving what's happening? And again, that's going to be limited by the experience and training of the officer. But they have the ability, once they've determined that in the affirmative, they can take the person into custody to a hospital and hand over that custody to the hospital ER staff, who then go about the business of getting a clear understanding of what's driving the behavior, what are the risk factors, what are the support systems, etc. And who are the other collateral people to be talking to in order to better understand what's happening. And then the MD makes a decision, because then it's handed over to the MD, and the MD then, based on his or her experience and training, will make a probable cause decision about whether or not this person can be safely treated in the community and discharged, or reasonably thought to be safe. I mean, none of us have any ability to predict what potential influences may occur outside of our awareness that will change the trajectory of that case. We just simply cannot control for all the variables that happen. And when someone goes into the community, of course, those variables are much more difficult to control, and so the risk is higher in some cases, many cases. Or they have the probable cause belief that this person needs to be placed on a mental health hold. And so then the person would then recommend a hold to a psychiatric admitting physician, and that person would then make a decision about holding the person in a psychiatric hospital. What has to happen there is that the physician who is making a referral has to know what the psychiatrist needs in order to make a decision in the affirmative to hold that person. In other words, there has to be a reason to believe that there's a mental disorder, and that mental disorder is causing the risk, and that other issues at play are not the primary drivers. Because one of the things a hospital is always looking at and looking for is, am I able to benefit this person? Is this the correct setting for this person to go into that I can effectively treat them? Or do they belong, can be better treated, translated, in another setting or another type of medical situation? Do they need to be on a medical unit or a rehab unit, et cetera, et cetera, et cetera? So that differential diagnosis that Tim was talking about gets more and more fine-tuned all the way through the process. Next slide. And again, one more click. And the director's designee has the same authority per statute as a law enforcement officer. The difference there is that the mental health professional or the designee has the authority to authorize a law enforcement officer to take somebody into custody. So in other words, the designee cannot take that person into physical custody themselves. They give that ability to a law enforcement officer who shall, according to the statute, then take the person into custody and transport them. There can be stick points in that conversation between the mental health clinician and the law enforcement officer. Both want to feel confident that the decision that they're making is the right one to make. And oftentimes when you're in the streets or in the memory care center or any number of medical clinic, any number of places where you might find somebody who's of a certain age and also experiencing aging related problems and also concerned about in terms of safety, health, there may be more or less information medically in terms of onset, functional impairments, et cetera. And so sometimes the officer and the mental health professional will disagree about the criteria being met for probable cause to take them into custody. But if the mental health professional does believe strongly and does so direct the officer is required by statute to take that person into custody, whether they're in full agreement or not. But it's always better to have that happen. And then conversations need to happen about how to do that in the least traumatic way, because you don't want to add to the problem by ending up with a wrestling match if it can be avoided, or having the person handcuffed and shackled in the back of a police car for their own mental health concerns. Sometimes that happens and is necessary, but if it can be avoided, of course, it just is so much better for everybody, especially the person that we're concerned about. To give you an example of probable cause, I'll do one quick story. I know Tim has 1,000 stories too, but I'm only going to do one that kind of gives you an idea of what probable cause can look like. In Spokane, I was doing an outreach because there was a concern about a couple. They were in their, I think, late 60s, early 70s. One of the people in the residential center, it was an apartment complex, said that they felt that these two were beating each other up and that somebody was going to get hurt, and there was some kind of vague concern about their mental health, although not very highlighted. But it was enough for us to go out because there was a concern about mental health, there was potential threat, they were elderly, they were frail, there was medical concerns, etc. So myself and my partner went out to see these two folks, and they were a lovely elderly couple. And it seemed as though the man was a little bit more fuzzy in terms of his cognition. He wasn't quite as sharp in terms of answering orientation questions, which were done in a very casual way. You know, what did you eat for breakfast this morning? Was it good? How did it get prepared? Things like that. And as I was looking over the individual, I noticed that he had a number of abrasions on his forearms. And as an elderly guy, he had the typical dryness of the skin and the thinness of the skin, and there appeared to be a number of welts on his arms. And that can be a concern, right? If you have that kind of a condition and you are experiencing a lot of abrasions, sometimes you can start bleeding and sometimes you can bleed a lot. So I began to get curious about that, which is one of the biggest skill sets that any of us can have, is just a natural curiosity and the freedom to allow ourselves to ask questions of any different type. So I asked him, I said, well, I see that you got some, you know, bruises and some bleeding on your arms and some welts that are come up and he says, "Oh yeah, Martha, she gets mad at me from time to time." And I said, "Oh, well, so Martha, what's going on?" And I'll shorten up this conversation, but basically she said, "Well, the son of a bitch won't go to work." And I said, "Well, Martha, actually what I didn't say, I didn't try to correct her and orient her to his age and that he'd been retired for, like 20 years or something like that. I said, so he won't go to work?" He says, "Yeah, every morning I get up." I said, "Oh, what happens? Do you get mad at him or something?" He says, "Yeah, I get up and I ask him, when's he going to get off to work? And he looks at me with this funny face and it just makes me so mad. I just, I'm just trying to get him out the door to go because he needs to work." I said, "Well, how do you do that?" She goes, "Well, I do this." And she picks up a hanger that she had rolled up together and whapped him on the arm right in front of us and hard. And I said, "Oh, I see. This is what happens." And so right at that point, I already knew I had the probable cause I needed to have her taken into custody if I couldn't convince her to go voluntarily. She was posing a threat to him. That threat potentially could cause him serious harm. And there was nothing that was going to stop her from continuing that behavior because it appeared that she believed that he was in his 20s and they should be going to work. Now, it was very likely that that ultimately resulted in a diagnosis of dementia or some other kind of a cognitive disorder. It wasn't clear to me at that time whether or not there was a mental disorder at play or driving this, but it was certainly possible that that was part of it as well. Because there was some relay of mental health history for her. So the custody really only allows for and provides for the ability to go into the mental health or to the hospital for further evaluation. So that probable cause can be used with a fair amount of judicialness, so to speak. It can be fairly broadly applied for that initial further evaluation, especially if the risk is present and going to be continuing and can't be mitigated. Next slide. And this is a flow chart for the director's custody, which is the same as it is for the police officer custody. Evaluation out in the community, transfer the transport authority to the officer, taken into custody, transported to the hospital, physician makes a determination. Next slide. Okay, Tim, you're on.
What the heck do we do? If I've heard Terry talk, a number of times. He's very good at what he does. And one of the things I often hear with him, and I hope others do too, is how complex these cases can be and how nuanced it is in terms of the decision-making process that's going on, because essentially a hold is all about taking someone's freedom away. Okay, so you don't want to do that lightly. And, so your skills actually now become paramount. And so, I know there's a lot of old dogs out there and maybe some new ones, but how do you get the skills besides actually going to a training is take the hard cases. Tell your boss, your director, whoever, give me the hard cases. That's what I want, because you're going to learn fast, and you'll learn how to, really make these choices, make these quick decisions that benefit in not only the client, but also your community. Anyway, that's my soapbox for the day. I'm old enough to be on soapbox a lot now, I have to tell you. But in any case, what do we do about this? I'm fortunate to I live in Bend, and we have a fairly good complex Gero case operation going on here. Nothing's written in stone. We don't have written agreements, at least not that I'm aware of. But it kind of works pretty good when we put our heads together. So you need to think about the future, because these complex Gero cases are increasing rapidly. Now, why is that? Well, of course, the number of people, the baby boomers, is increasing very rapidly, and they often don't have good health care, contrary to popular belief. There's a lot of them who don't make anywhere near as much money to live comfortably. In fact, that's the dominant group within baby boomers. Another thing that's going on in the background here is that people with major mental illnesses, like schizophrenia, who, early in my career was, well, we all know these guys all live about 25 years less than, say, the average lifespan. And that was true for a variety of reasons. Well, that variety of reasons is kind of going away, and these folks are living into natural lifespans despite their schizophrenia, primarily because of medical services and psychiatric medications have improved so dramatically in the last couple, like 20 years. They're able to grow into having dementia at normal typical ages of onset, usually a little earlier because the schizophrenia and the drugs for them can degrade your cognitive status, kind of in a nasty way. But in any event, there's more of them out there and there's more coming. And at least in terms of skill sets and that sort of thing, we can prepare for that, while we're agitating with our political folks to fund us to do that. So build and enhance interagency relationships. I mean, this is at all levels, it's possible. I can remember being conscious having to do this because when I arrived here, it wasn't happening amongst the elder care community that existed at the time. But it was really important to do so because, alone, I mean, many of you I know, you're dealing with these complex cases and you kind of feel alone. Who do I call? And so, you got to kind of warm that up in terms of who you're going to call and know who it is, know how many kids they got, quite literally. And, don't always go to an official meeting, meet them for a beer or a cup of coffee or something like that, where, you can form a relationship that begins and ends with professionalism, but also that natural human friendliness. And you can do that, the smaller the community, the easier that is. But Bend is a very large place these days, very busy, and it still happens. Okay, but it takes work. It's not something that's not organic. It takes work to do that. So here's a big one, is create an issue presence in Salem. Okay, representation equals resources. Now, back in the day, I was on all manner of work groups that didn't seem to be related to geriatric mental health. Well, I don't know if I said I'm retired from Deschutes County Mental Health. I was the geriatric person there for over 20 years. But I used to be, part of work groups that didn't seem to be related to that. And I'd always be bumping into other people from Deschutes County that, from different agencies, both government and nonprofit, they're in work groups and they're here and there advocating. Deschutes County was known as the state of Deschutes because of that, because there were so many people there representing the interests of the people of Deschutes County, not just the elected representative. That definitely caused us to get so much more money percentage-wise than other counties just because of that, even when we weren't asking for it. The funders had good relationships with us for other reasons. They were much quicker to sign on the dotted line. So, get on local and various state committees and work groups, always have a presence. Doesn't have to be about solving Gero-Psychiatric cases. It can be about a lot of other stuff. And educate and advocate with your local state reps on, that was a Freudian slip, but your local state reps in geriatric and mental health issues. Educate them. Let them know what's going on. Let them know about that Oregon statute that requires representation in the county mental health agency, which I'm sure they don't know about. Don't let them slide on this. They're the primary source of funding for various things going on, at least in a government way. Grants, of course, are the other way. But they need to be educated, and you do that the same way as you do with other folks, form a relationship, get friendly. You walk in, they say, "Hi, Tim, how you doing?" Okay. So involve the area representative of the Oregon Older Adult Behavioral Health Initiative. Okay, now GOBI in Eastern Oregon and up on the coast, North Coast, is the private nonprofit and for mental health, and also they employ the Behavioral Health Initiative representative. Every community has someone that represents that. In the case of Eastern Oregon, they may be representing several counties. the one here in that's located in Bend, they represent a tri-county area. Okay, so this is a person who, this is a state grant funded thing that came about 5 or more years ago. And, it's designed to build and enhance geriatric mental health services. So this is a person who, does already or should know anybody and everybody in your community who's got some remote or direct link to geriatric mental health services. So they are a key player, or could be a key player in, dealing with these complex gero cases. Okay, so figure out who it is. You'll see in this slide a name and contact email for the person in the state in Salem who is the statewide director of this program. They'll be able to tell you who that is for your community. Okay, so get a hold of them. So the local mental health agency probably, almost certainly has a complex care team, as well as someone who does after hours crisis. This is often the person who is a kind of a first contact with what evolves into a complex gero case, but know who that is, know what their phone numbers are, how do they do that? How do they orchestrate after hours crisis and what's about their complex care team? How does that team take on, a case in the community? So in any event, so you might guess before I get to that actually bullet point, I'm talking about developing a team. This is a team sport. It doesn't work well without a team. Okay, so if your community doesn't have a mental health person who specializes in geriatrics, well, help that to happen. Help the county develop that with money, with training. Pull some money to send them to trainings. There's good trainings happening around the state, and client referrals. Dump the hard cases on them that they got to take, like difficult Medicaid cases. They can't say no. They can learn that way. Okay. So find and develop a psychiatrist, neurologist, general practitioner who could be an NP or a PA that's willing to become involved in these cases. Often these folks do not have primary care, haven't seen a doctor in a long time, got a lot of medical issues going on that may or may not be treated. So they're going to need a doctor. We all need a doctor, if for no other reason, because a doctor is going to be necessary to, say, sign something to get a older adult into a nursing home or assisted living or something. They need doctor's order. Can be difficult, to find a psychiatrist who's willing or able to deal with geriatric issues. Not every psychiatrist has a clue about geriatric mental health. Often they do not. Neurologists often don't want to get involved with someone who doesn't have dementia, but they usually will if they do have that diagnosis. They're the ones who would get that diagnosis most proficiently is a neurologist. And so again, you need that for assessment, for treatment, for placement, and they need to, all these guys need to understand, and if they're going to become involved here, is that, mostly you got Medicare, Medicaid to pay the bills, but, they'll probably end up having to do some pro bono work, okay? A private practice psychologist, social worker can be utilized. I do that in this community. I get called on to do assessments for complex gero cases, often. I don't get any pay. I think a jail system paid me $50 one time to help them with somebody. That for all the work I've done, that's how much I've gotten paid. But that's okay. I'm willing to do that, and you'll find a lot of folks like that who are quite willing, as long as you don't lean on them too often. Next slide, please. Okay, so again, we're talking about creating a county or area-wide interagency complex care team. Mine is a 3-county area: Deschutes, Prineville, and Madras. Those we're in this together because our older adult behavioral health initiative representative is the one who coordinates the complex care team. She took that on very readily. She's very adept at it. She's very good. We're really quite glad to have her doing that. So you're creating this entity to work with, to find service options and solutions for complex gero clients. even if it's not your agency's client, this is an important concept. If this isn't a Medicaid person, well, that's technically not a state client then. But if the state persons is part of the team, they're contributing their knowledge and expertise, to this solving the issues. The same with any other involved agency. Okay. Now, all players who are interested in this issue contribute a member who are timely and involved. No, this isn't, you haven't had a complex case in 2 months, so, they're not showing up at the meetings or the Zoom calls or whatnot. No, it's timely and involved, because when one of these start, they usually start with a bang and everybody needs to step up, and so people need to be involved, kind of all the time. Again, it's not just with your clients. This client is at the mental health agency or with the local AAA, but not yours. You step up and you dive in, you give the time. Your agencies, need to know that you're a part of this group and give you allowance for or permission, whatever it takes to be a part of it, to utilize your time and resources to solve this. Because this ultimately is a community problem and it has a way of expanding when not addressed timely or correctly, and ends up costing lots of different people a lot of money. As we're talking here in part because these are the single most expensive cases in the system, are geriatric complex cases. Okay, so other players, not my client, they're going to be saving money too. Okay, so here's some ideas about who your team might include, who you recruit, but this isn't limited to this. Be creative here. The local state agency on aging, they're called different things in different areas, but they're a key player because if the person is non-Medicaid, they're often eligible for Medicaid. And of course, the state is connected to all the various elder care facilities and can often facilitate admit to these places. So that would be the specific case manager is assigned from any office, or adult protective services. If there's a different client comes aboard that has a different case manager, that person is temporarily part of the action as well. But that initial one, that one that's there permanently, he doesn't go away for the duration of the case. Okay. The local AAA area agency on aging, they're called different things in different places. Ours is Central Oregon Council on Aging. The other geriatric service agencies can become involved, and especially if they do have a lot of that crossover in that slide one, people who meet, 2 or more of those specific criteria. City and county police usually almost always get involved at some point. So having a rep, that comes to all the meetings, and often they know may have long experience with these people before they kind of reach this kind of complex level, through a variety of reasons, not just crime, but because they're homeless or they show up at the emergency room frequently. The police will often know who these folks are. The mental health agency specialist, again, from the complex care team, or if you're lucky enough to have a Gero specialist, that person should be, on the team. Veteran service group often is a good people to have because gosh, I would guess probably a third of the complex cases I've dealt with in the last couple of years have been veterans. And so it's good to have a veteran person on the group. We have, again, we're lucky enough to have a great one in our group. The homeless shelter often is very much involved in some of these. So somebody from there would be great to have because they usually have knowledge about all the various services and all the little angles to get to the services, what isn't available. A local geriatric specialist attorney, if you have one, is good to have, if not be on the team, but be in close touch with, because they'll be necessary for understanding what geriatric law is, which can be a little bit different, but also in getting guardianships and whatnot. That person can sometimes be paid, but they should know that they may be doing pro bono services. The medical clinic, whoever the person's PCP is or will be, become the PCP. We have a low-income clinic here that has readily stepped up for that in different communities. We're real happy with that. or any involved specialist, neurologist or psychiatrist or something, if one's already involved. The state guardianship office, well, yeah, you don't need the state guardianship office to get a guardian. They're off their last ditch kind of effort. They do have a very limited amount of funds to pay for guardians, but in any case, have knowledge about how to acquire a guardianship and who in your local area is willing to become one. The local long-term care ombudsman can be very helpful, again, for knowledge of the person, but also knowledge of services and who you might be talking to. Hospital, emergency department, social worker or RN, again, they often will know people because they filter through there frequently, but they also know about the dynamics of their hospital, what they can and can't do, what doctor to access for different medical problems. Again, or older adult behavioral health initiative representative. We're lucky in our area that ours has stepped up, has a willingness and capability to operate a complex care team. Yours may or may not have that, but they don't have to be the one who runs the team, but they will have some knowledge about geriatric mental health resources and their mental health status, and how to understand aging and mental health, how they all start flowing together there. Other agencies on a per needed basis, such as jail people, volunteers of various kinds, family members can be invaluable, especially for becoming guardians. Church service groups sometimes get involved, especially with homeless. But all these players, become either a part of a permanent team, or you've identified ones who will, come and go on an as-needed basis, such as, somebody at the jail. Usually it's a jail social worker or someone who acts as one. Smaller jails don't necessarily have one. Okay, so you designate a team leader, again, willing, but, hopefully able to put it all together, knows or can learn, who to call for specific needs. One or more of us might know who to call, but, everybody really needs to call, especially the team lead there, both locally as well as statewide. I mean, most of these cases that I've dealt with recently have been placed out of our area, over the mountains. And, we've had people that know these facilities and know what their admit criteria is. And that's really valuable. If you don't know that, know who to call somewhere who knows what different facilities take what kinds of clients. So not just knowing a placement, but who knows about placement things, okay? So in terms of, a lot of these folks are part of an agency, say someone at the local AAA or the local mental health agency becomes the team lead, but whenever people take over like that, they have to become, somewhat agency neutral when they're taking on a case. I work for mental health, so I'm constantly advocating for mental health no matter what is going on. You really have to kind of tone that down and become more of a team, think of it more of that way. And there's also a term here, which I can't remember if it's on the next slide or not, but financially agnostic in terms of who pays. That's not a first question. Everybody, who's going to pay for this case? Okay. Get paid for older adults, again, Medicare, Medicaid, they may not be accessing that. They may not have a clue how to, they don't know what their Medicare number is or even what that means. But, you can develop that. Okay. And again, given how expensive this stuff is, even if everything happened and nobody got paid, you've saved a lot of money. Okay. Next slide, please, Eric. So team members and their supervising agencies got to be willing to devote time to learn these new and improved knowledge and skills. Again, numbers are increasing rapidly. This confluence of schizophrenia and dementia, it's been a long been an interest of mine because it's so fascinating in terms of how it kind of plays out on the street or in somebody's home or care facility or something. So, I kind of know some about that, but only because I took an interest in it. There's not like there's, trainings anywhere about that sort of thing, but it's common in complex care. And so learning some about it is important, as well as, you're 82, you take fentanyl and you drink too much, and you also take Benadryl at night because you can't sleep without it. You got a complex case right there, and that's common. It's very common. Okay. Again, agencies need to be willing to devote time and personnel and maybe money to learning about this stuff. Okay. Because it's going to hit you pretty hard if you don't. Consider the power of groupthink. And we all know this term, wraparound services. The child service people are very familiar with it. Not so much in Gero care, though. It really needs to be just an automatic part of Gero care if we're going to be dealing effectively with these complex cases. So, it's the groupthink, the whole team putting their heads together, strategizing and all that. So much more powerful than, one person, I don't care how good they are, trying to do it themselves. So developing, local Gero wraparound, that's a good first effort, because the team is going to be doing that. People identified in all the various agencies, who to call. This is a way to really start getting things rolling. If you think about wraparound and team, becoming well educated on HIPAA rules. For instance, this person's in crisis, particularly one that involves, their health and safety. Oh, I can't tell you that, man. Because HIPAA and all that. No, that's wrong. HIPAA is blown way out of proportion. Very few people have an intimate understanding of it. I won't claim to myself, but I know when I can say stuff and when not to, and when the interests of a person's or someone else's safety is involved, I don't even think HIPAA. Okay, but it's important to really know what that is. Have at least one person on your team that can, really knows those rules. Okay, another very important piece, somebody needs to know the intimacies of legal capacity. Okay, and there are intimacies and nuances, and not just, well, do they have dementia or not? No, I get involved in assessments all the time about, trying to, kind of parse out, well, yeah, they're in a memory care agency, but do they have the wherewithal to get involved in a sexual relationship? Well, one would say, no, they're in memory care. But, there's different nuances there where we can know they have capacity. For instance, another example is a frontal lobe dementia. They may have 100% ability to operate their finances, no problem. Well, then how do they have dementia if they can do that? Well, they can have frontal lobe dementia and have lost the ability to control themselves in public and know the real differences between right and wrong. Those people end up on the street frequently because they've violated their families, they've violated their workplaces, and they end up on the street. And they can be very, very difficult to deal with. And if you don't know the nuances of legal capacity, you could miss that they have dementia and an inability to care for self. Okay, so that's just one example. Some designated person, and don't assume that the mental health person knows it all. Somebody needs to really be clear about that, or you need to know somebody to call. Okay, so learn all about legal guardianship and conservatorship. It's not just, just get them a guardian. Okay, getting a guardian is like putting you in jail in a sense. You are removed from your freedom and your freedom of choice, freedom of movement. And, that's important stuff. We don't do that lightly, okay? People don't want guardians. And if they fight it, now the court is paying for a lawyer to fight you on it. And so you need to know exactly what's going on there. This is about getting a relationship with the state guardianship program will go a long way to, help educate you and get you resources if, in fact, you need them. Not all problems are solved by guardians, because remember, a guardian gives you decisional capacity. It doesn't give you coercive capacity. Okay, Joe, I'm your guardian. You're going to the nursing home over there, and he's, yeah, with you, I ain't going nowhere. You can't tell a police officer to go take him there. Okay, that's not part of your power. So you got to know the little pieces of that. Have a local lawyer that knows geriatric law. There are stuff that's different from just law in general, particularly when it comes to estates and money and guardianship law. Most of them will know that. If they're in a Gero, they usually know guardianship stuff. If you don't have one, at least develop one you can call for some advice on the phone. They have to know, they will know, of course, that a lot of this might be pro bono. They're going to want money if they have to go to court, and that's reasonable. But you can develop relationships where you can talk to them on the phone about potential and possibilities and things like that. That's a really important piece of it. So work to overcome issues related to HIPAA, service silos, who's paying for what. It's not my job attitude that so many different agencies have with each other. For a team, for the community, it really is everyone's job because everybody benefits, So here it is. Yeah, team becomes payer agnostic. Don't worry until much later, until you're starting to look at success, where the money's coming from. Keep an accounting of, billing hours and all that. So if you end up billing Medicare, there you got that record. But, don't let that be an impediment to someone's care. I think that might be the last one. Next slide. Next slide, Eric. That must be the last slide.
The last one.
Last slide. Okay, great. So we got 20 minutes for questions.
Tim, before we do that, can I make a couple comments? There you go. So, yeah, I just wanted to support a couple of things that Tim said before we go into questions. One is, I think as a general rule and principle is that through the collaboration, you find opportunities and you begin to understand where the obstacles are that everybody's experiencing. The collaboration is what kind of helps define and flesh out who can do what and under what circumstances within their own authorities and scopes. And that helps you begin to see where you can work collectively to solve a problem. But behind that, you need to have that understanding that this is a shared responsibility and a shared problem. And turning that corner between pushing the liability from one place to another or trying to get another agency to do something you cannot do, that becomes a challenge that creates a lot of conflict within your system and a lot of frustration and a lot of fatigue. So as your agencies make that kind of meta understanding that this is a shared responsibility and we all collectively benefit by working together collectively, and that we can create agreements that allow us to communicate with each other within confidentiality agreements and interagency agreements that do allow that collaboration to occur within the safety of the system, and that's excellent. The other thing I would also say is once you have a system like that put together, or in the process of doing that, institute it into your policies and procedures. Because sometimes the leadership moves on to other things and does other things, and if it's only attached to the person, you'll see those programs begin to diminish in their activity and begin to pull apart because it's not a policized process that is part of the institution now or the fabric of the community. So make it policy, do the interagency agreements, have them working together, and review them on a regular basis. The other thing I would also just add to what Tim was saying about the guardianships is they're not all built the same. Some guardianships only have an authority over a person's finances. Another guardianship may have the ability to authorize certain medical procedures, but not psychiatric procedures. And then another guardianship can have financial, medical, and psychiatric authority. And so if you are trying to get somebody into a psychiatric hospital and the guardianship doesn't have that authority, then it won't be able to open that door for the physician to make that determination about admission unless that person is willing to go there voluntarily. And so not all guardianships are built the same. And so be sure that you're working towards the guardianship that provides you the level of authority that you need to address the needs of the case. And I think the last thought I want to leave before we do questions is these things are complex because they're complex, right? I mean, they are challenging because they're challenging. We wouldn't be talking about this if it was easy. to manage, and our system was built for it. And our capacity right now to deal with this has been even further diminished by the pandemic, partly because this is a very sensitive population to the pandemic and sensitive for being affected by it. And so the capacity within the agencies that exist to provide this service has had to be cautious about how many people they bring into their facilities. And at the same time, we already had very little capacity for this kind of work in the first place. And so that capacity impacts the way we think about it and the way we approach it. And I think we have to be mindful of that and careful of that to not have that capacity cause us to be narrow in our thinking and our scope, and so that we can stay flexible, stay adaptable. And as Tim was saying wisely, it's really about the relationships you form with one another that allow you to manage and cope with the stressors of this kind of work. So I'll stop with that and go with questions. Thank you.
Well, thank you very much, Tim and Terry. A very informative conversation here. Let's get into a question we have, and it was, Tim, you certainly touched on this a little bit, and perhaps this is an opportunity to elaborate, but a question coming in about HIPAA and how to manage HIPAA and confidentiality concerns or questions with the interagency complex care team.
How to do that? Well,
yeah, how to manage that.
Well, one could, well, if you got, say, 8 team members, you're likely to have, 6 or more ideas of what HIPAA can and can't do and what the laws are around it. It really isn't complex. You could probably find just go to PowerPoint's HIPAA on Google, and you'll find some good PowerPoints of what HIPAA is and what it can do. It can be that simple to really get a grip on understanding it. I think the main thing to kind of know in this situation, if you're not in a crisis, you're kind of at a crisis, or one's impending here, and that information can be exchanged under those circumstances. Okay, and I've never known of anyone to be prosecuted under HIPAA law anywhere for anything. We are overly careful about this sort of thing. We're talking about someone's health and safety, or someone else who that person might harm. That eliminates these contours around HIPAA. And so, again, part of the team, one person can take on, the relatively simple task of understanding how HIPAA relates to this type of organization, and then just educate the rest of the group. It really isn't. It can be as simple as going to PowerPoint presentations, HIPAA on Google, and you're going to find all the stuff you need.
All right. So another question coming in from Ginger. How do you access the state's guardianship program?
Let's both, Terry and I, give you that. It's a state organization. Always, so therefore you can just access it directly, look it up online, but the local state aging office has got relationships with these people already. It was, initially anyway, thought of and created for Medicaid and low-income people. It's expanded to include other people in need, although it's still mostly that. And so state case managers, or if not them, their supervisors will know about the local representative. Everywhere in the state has a designated representative. They may or may not be in your community. For Bend, our representative for that program is in Salem. Okay, but they're accessible on phone and Zoom and everywhere else. And so you could probably most easily just look it up online and find contact numbers. Terry?
A couple of things about the guardianship too, from a civil commitment point of view. Sometimes guardianships are considered what we would call a less restrictive alternative to a commitment, in that it provides the authority for admissions, medications, that kind of a thing for somebody, and doesn't require a civil commitment, which is much more stigma producing and much more trauma involving. And this is a much better kind of relationship in most cases. The difficulty with guardianships is that they're sometimes difficult to happen in a short period of time. They cost money, and it's difficult to identify a person willing to be a guardian in that short period of time. Remember, when we're talking about civil commitments, they happen within 5 judicial days once the hold has taken place. And so it's unusual for a guardianship to be instituted before the civil commitment can occur or has to occur if there's going to be one. But there can be emergency guardianships that are then followed by a full guardianship hearing that's like 30, 60 days later. And so in some circumstances, if you do have the money, the guardian identified, and you have an emergency circumstance, it is possible to get an emergency guardianship if you have all that magic at once. But in most cases, it takes a while for all of that to be put together if you can find it. The other thing to keep in mind with guardianships is they are limited to what they can do in some respects, especially around psychiatric care. For example, a guardian can provide the authority to have somebody admitted to the hospital, but they don't make the decision, as Tim said. That decision's authority rests with the physician. So the guardian can provide, if they have that kind of authority, they can provide the permission to admit and feels like it's medically necessary. So you have to have both those things in place. Secondly, if an individual, for example, needs psychiatric medications and the individual is refusing to take those medications, the guardian can provide the authority or the permission for the medications to be prescribed, but still the physician has to go through the due process rights of emergency medical override for an individual. And so the guardian doesn't have the ability to give the physician to do the medical override unless it's medically necessary per the statutes and the rules around that. So again, there's a limitation to the scope of what a guardian can do, and it's important to understand that, because still you have to have that collaborative relationship. And Tim is also right, under emergency circumstances, the care coordination does take a precedence over the HIPAA requirements. Going forward, though, it's important to have the agreements in place that provide for protection of PHI, private health information, when you're doing these interagency, intergroup collaboratives, so that there is some sort of a structure in place that acknowledges the maintaining of the confidentiality within that process. And I'll stop there.
Thank you. Question coming in from Kristen with regards to, and I know that this is an issue in a lot of communities, but their real issue is that there are no residential facilities in their area once a decision's been made. Any comments to that challenge?
Well, that's a challenge in all communities. Despite, a relative plethora of services and facilities here in Deschutes County, we don't have any residential facilities here. And like I said, the last several ones I've been involved in, people were placed over the mountains. And so really you have to identify, again, someone in the group here is finding this stuff out. Often people work for the state, the case managers, they know about care facilities and things like that, or they have easy access to people who do. I mean, there's a couple of people that work for the state in Salem that I call, for a variety of reasons about facilities. And, they just know them all. They've been dealing with it for years. And so you need to identify, who those people are, not just where can they go, but who do I call in that place, individual place, or who run, there's somebody at the state who actually organizes and coordinates admissions to residential care facilities. And so knowing who those people are is, where you start, okay? Because most communities do not have any kind of psychiatric care centers or residential communities or anything like that. That's the most common scenario. Okay.
Yeah,
so
I would.
One of the things, I'm sorry. Go ahead.
Add to that too, Tim, to say that we recognize that you have short-term immediate needs that are being unmet in terms of capacity for the system to address the needs that you've identified for people. That is the way it is across the state. Part of what we're saying in this presentation, I think, is that immediate need and stressor exists, and we recognize that, but also take a long view on this too, in terms of developing and working towards those collaborative relationships so that you can develop resources over time that are going to be more responsive than the way they are right now. But we understand that this is an uphill climb, and you have people who need things right now that you're struggling to find access for.
So it's important to, have a lawyer handy in your community who can, again, answer questions about guardianship, HIPAA, things like that, who simply can, guide, does this person need a guardian? That sort of thing. And I want to make sure I say something about, the fallback, which seems to be a fallback and it isn't, is, we'll send them get them on a hold, send them to the state hospital, or, send them to one of these Gero-Psychiatric hospitals, Tuolity or, one of those. That is almost always not an option. Okay, so begin your thinking about what to do before that comes up. If you're violent, if you have dementia, you're not going to a Gero-Psychiatric hospital. If you don't have a guardian, you're not going to a Gero-Psychiatric hospital. Okay, and Terry could tell you how very difficult it is to be admitted to the state hospital. And so those if those are part of your kind of fallback position or, go to first kind of option, I would adjust your thinking about that because the opportunities there aren't even close to what they used to be, even 5 years ago. 20 years ago, yeah, we could have that number one option, send them to a Gero hospital. That has changed dramatically. And it's not even in my playbook anymore. That's how devolved it has become.
Tim's right about that. There's been significant lack of capacity at the state hospital level. There's been a number of factors why that is. Of course, we've had a series of closures of state hospital facilities over the last several years. And currently, the Oregon State Hospital in Salem, the vast majority of the people in those hospital beds right now are your Psychiatric Security Review Board clients, which are statutorily required to be placed in the state hospital if they meet the correct criteria. And you have the 370 aid and assist court-ordered evaluations, also statutorily required to be in the state hospital. And both of those situations are impacting the ability for civil commitment folks to go to the state hospital. And right now, currently, there's only like 40 beds that are filled by civil commitment folks. And that's of all types of civil commitment folks. Those people who meet that criteria, there's only 40 beds for that. And even at this point, I think there's probably no movement from the acute care hospitals to the state hospital because there's no capacity for that. And of course, the pandemic has also made that more difficult. And in addition to that, there, as you've probably many of you read, there's been some staff shortages at the state hospital level because of just the stress and the wear and tear on people. They've lost staff and they're having trouble replacing those folks. So the state hospital, as Tim said, is really just should not be part of the playbook in terms of an expectation of relieving what you providing the resource that you think this person needs, whether that is the need that they have. Getting that access to that resource is really, really difficult. And on top of that, within the system itself, it's baked in for people to not be civilly committed if there is any other alternative to that civil commitment. It is the statutes are very clear about the civil commitment should be an avenue of last resort, of absolute necessity, where everything else has failed, not because it benefits them. And that is oftentimes the case, that civil commitment does benefit the individual, but the driving reason for a civil commitment is because nothing else would work. And so what you see is if you have 10 people go to the hospital out of custody, like I described before, maybe only one of those people are going to be placed on a hold for a civil commitment evaluation. So 1 in 10. And of 10 people who are placed on holds, well, maybe only one of those people who are on a hold are going to go to a civil commitment. And so if you look at it in the number of 100 people that go from the community to the hospital, only 10 out of 100 will actually be placed on a hold. Once they are placed on a hold, however, typically speaking, about 90% of those folks do end up under commitment. But it is very, very difficult to get that person all the way through that stage. And once they get to the civil commitment hearing, the bar is no longer probable cause. The court has to be shown evidence that this person meets clear and convincing evidence of a commitment, which is a much higher bar. It's a middle road bar between that and beyond a reasonable doubt for criminal cases. So the evidence requirement's real high. The system is built to defer people away from civil commitment. And we have a capacity problem too.
Yeah, Terry, could you just give a brief word as to what that means to be under commitment and how do you get there?
Yeah, so the commitment results in a hearing where you have the state represented for the commitment, along with an investigator who does the investigation and provides a report to the court recommending a hearing. The civil commitment hearing also has a person in there called an examiner, who is an independent counsel advisor to the court as to whether or not the mental health diagnosis criteria has been reached and whether or not this person, in their opinion, meets the civil commitment criteria. It's like a civil hearing, but the evidence requirement for that is that the person is shown with very clear evidence that the person has a mental disorder. And so you'll have witnesses like physicians and psychiatrists and other folks providing testimony about that, about the diagnosis. What is the diagnosis? What are the functional impairments? And how do those functional impairments result in risk in the near future? And then you have the examiner also doing that, questioning of witnesses. And through the course of a hearing, which is 4 to 6 hours in most cases, the court then makes a decision as to about whether or not that evidence requirement has been reached. And then there's decisions made about where the person goes from there. And that's an important piece. So again, if a person's civilly committed, they usually return back to the acute care unit from which they were at, which is what we're seeing now. And so a lot of these acute care units are having capacity problems because they have people who have been civilly committed and waiting to go to the right level of care, but they can't get there because there's no capacity for the state hospital or long-term psychiatric care. And so they're having to make really difficult decisions about discharging people who should have a higher level of care because it doesn't exist. They have to think about it, discharging them into the community at a level of care that maybe is barely adequate to meet their needs and provides too many opportunities that anybody's comfortable with for the person to not do well. So there's a lack of capacity in secure residential treatment facilities, residential treatment homes, etc. The civil commitment is for 180 days, up to 180 days, and that person can be recertified for a second period of 180 days and so on. But there's criteria that has to be met for that. So it's a fairly complex process, and a lot of people get heard by the court before the court makes that decision.
All right, fellows. Well, we still have questions that hopefully we can get together and answer offline because we are approaching the top of the middle of the hour. But one quick question that I hope will be is a quick one. Terry, question for Terry. When you do trainings, commitment trainings, how does one find out about them and who's able to attend?
Great question. Thank you. I do trainings now online because of COVID. Before I did them in person, and actually I'm able to do them more frequently online than I used to be able to do them in person, and they're more accessible to people. In fact, I do a civil commitment training every other month, and I do an examiner training the opposite months. And I send out an announcement to all the CMHPs informing them that I'm providing a training, and when those days are. The training is a day and a half, and I have been adding more people from the community, different stakeholders, to these trainings, social workers, attorneys, any number of different folks who have an interest in learning about this process. And so typically you can just give me an email and I'll let you know when the training is. It's designed for people to be investigators, but it's often very useful for other people who are a part of that process to know how it works, what the requirements are. So
You know,
just get an email.
speaking of trainings, this in the earlier slide, I gave you a name and an email of Nirmala Dar, who's the coordinator for the Behavioral Health Initiative, for you to, just access her and she'll let you know who that representative is for your area. But also she gives many awesome trainings. She's like a really brilliant gal who gives great trainings on all manner of topics related to geriatric mental health, including capacity assessments and hoarding, how to deal with hoarding, an old person hoarding in the community, a lot of different stuff. So when you it's as simple as getting on an email list, in terms of when she's doing stuff, but you can also ask her to do trainings in your community, and she will. That's part of her job description, and she's very good at it, and it's always free. So find out what she's doing in that regard and how to get her to do stuff for you.
Yes, and I will add, we just had Norma at the last session, and so I think this would be a good answer to your question, Antoinette, about dementia and capacity. You can see previous recordings of sessions, so if you all have questions about dementia specifically and want to access Normala's presentation, it's available on the forum webpage. She has her contact information there, and she encourages anybody that has questions to reach out to her. So really great team, the three of you, as far as resources and getting some of the questions answered in the chat. For folks whose questions that we did not get to, I will send those over to the presenters and see if they have some feedback for you and get them back to you. So thank you all to everyone here. Terry, Tim, thanks for sharing numerous decades of experience and information to everybody that was on today. I do apologize. I guess we could have gone for about 2 hours at least with all the questions that we have coming in. Geriatric mental health is Nirmala Dar, and again, her presentation and information is available on the Forum Oregon Office of Rural Health Forum on Aging in Rural Oregon previous session. So there's a couple questions coming in about that. Thank you so much for being here, everyone. Have a lovely remainder of your day. And again, thank you, Tim and Terry, so much.
You're welcome.
Thank you, Rebecca.